يعطيك العافية. السلام عليكم ورحمة الله وبركاته. معكم آيات. إن شاء الله حبدأ معاكم الشرح الكيس الخمس كيسات الأوائل عندنا اليوم. حنبدأ بالكيس الخامس عشان الكيس الأول حيتأجل لبكرة بإذن الله، بس حنبدأ بالخامس بعدين نكمل الثالث والثالث والرابع. طبعا أعرض لكم الشاشة. السلام عليكم. الشاشة واضحة عندكم؟
إيه واضحة.
تمام. يلا بسم الله على بركة الله نبدأ. السلام عليكم ورحمة الله وبركاته. نبدأ كيس 5 إن شاء الله اللي هو هيتكلم عن الهايبرتنشن. So first, before we talk about the hypertension, we will start by the hemodynamic principle of the blood pressure. So we have short-term regulation and the long-term regulation. For the short, we will start by the short term. First, we have the baroreceptor. As what you see here in the picture, we have the baroreceptor, which is located here in the carotid sinus or the carotid body. Here we have the chemoreceptor. Also, it's located in the aortic arch. So, from the carotid body, it will go by the hearing nerve to the glossopharyngeal nerve, and then will stimulate the medulla. So first, what will happen? When we have increased blood pressure, the arterial blood pressure is rise above the normal range. So the baroreceptor in the carotid sinus and aortic arch will be stimulated. When they are stimulated, this will lead to inhibition of the cardio-acceleratory center, and this will inhibit the vasomotor center, so will decrease the blood pressure. So we'll start by high blood pressure, and then we will inhibit the cardio center or the cardio-acceleratory center, and then we will get decrease in the blood pressure. Okay, decrease in heart rate, contractility, and the cardiac output. After that, this will return the blood pressure to the hemostatic range. And what happens when we have decreased blood pressure? The opposite will happen. So the baroreceptor in the carotid sinus and aortic arch will be inhibited, and this will lead to activation of the cardio-acceleratory center. So we will have inhibit the cardio-inhibitory center. This will lead to stimulation. So this will make increase in sympathetic impulse and increase in the heart rate. So we'll have high blood pressure because we start by low blood pressure. Okay, get it? Moving to the next slide, we have the next short term. We have the chemoreceptor. Okay, the chemoreceptor, it's relating to the gases. So if we have hydrogen ions or bicarbonate and the cardiac and the oxygen level. So, and why it's relating to the blood pressure? When there is an increase in the CO2 or decrease in the O2, so this will lead to decrease in the pH. Okay, when we have decrease in the pH, this will stimulate the excitatory impulses through the vagus nerve and the glossopharyngeal nerve. This will increase the respiration. So why we talk about this in the blood pressure? Because when we have decrease in the pH, then we will have also decrease in the blood pressure. So this will increase the respiration and also increase the blood pressure and the vasoconstriction, make vasoconstriction. So we'll have increase in the blood pressure. Okay, get it? As you see here, we have the medulla center in the medulla. This is the chemosensitive area here. And also we have another principle in the short term when there is cerebral ischemia. So we have increase in the CO2. This will activate the sympathetic system and increase it. So we'll have increase also in the arterial pressure. This is the second short-term regulation of the blood pressure. Okay. In this slide, we have a comparison between the baroreceptor and chemoreceptor. You can see it, and it's the same as what I explained before. The third thing that we have here, which is the arterial natriuretic peptide, which is a very important thing in the regulation of blood pressure. So it's relating to the volume. Before it's related to the pressure. The baroreceptor relating to the pressure, but here it's relating to the volume. When we have increase in the volume of the blood in the heart, the atria will expand. So when it's expand, it will secrete the A and B. Okay. So when we have this hormone or this peptide, will try to decrease the blood pressure. Okay, by increasing the GFR. When we increase the GFR, what will happen? Then we will have diuresis. So from its name, it's natriuretic, meaning putting the sodium in the urine. Okay, so we'll increase the GFR, making the sodium and the water, all of this in the urine. By this, we will decrease the blood pressure, right? Because we start by increasing in the volume. So we want to decrease it by this peptide. And also it will decrease all the things that will increase the blood pressure, for example, the blood volume, the cardiac output, the renin activation, the angiotensin 2, aldosterone, all of this will decrease it because we want to decrease the blood pressure, not increase the blood pressure. Okay? Until now, it's clear? Okay. So let's complete. Okay, tamam. Let's complete to the long-term regulation. We finish from the short term. We have the baroreceptor, chemoreceptor, and also we have the A and B. And then we'll move to the long-term regulation. I think you have already talked about it a lot of times, so I will make a summary for it. So we have the main thing in the long-term regulation, the renin angiotensin system. So when it will be activated, when there is a drop in the blood pressure. So when the kidney feels like there is a drop in the blood pressure, drop in the fluid volume, what will happen? The kidney will start to secrete the renin. Usually there is a beta-1 receptor in the kidney. When it will be activated, the renin will be secreted. So by beta-1 receptor, it's very important. Okay, beta-1 receptor, the one which is responsible for the renin release. So what will happen if the renin release? It will go to the kidney and activate the angiotensinogen to angiotensin 1, and then to angiotensin 2. And from angiotensin 1 to 2, it will be by the ACE, which is angiotensin converting enzyme, which is released from the lung. Very important also. Then this angiotensin 2, when it will be activated, will have constriction in the blood vessel. Its main function to constrict the blood vessel. So by constriction the blood pressure, then we will have increase of the blood pressure. Okay. And also, the angiotensin 2 has another role, which is in the aldosterone secretion. And we know the aldosterone acts on the kidney to stimulate the reabsorption of the NaCl and water also. So by this also, we will have increase in the blood pressure. Okay? This is the main principle for the blood pressure regulation. And here we have when we have the blood pressure, it's either be relating to the cardiac output or to the peripheral resistance. Very important, this picture, okay? First, the cardiac output. First, we'll talk about the blood volume. So if there is excess sodium or mineralocorticoids, and arterial natriuretic peptide. This is the thing that affects the blood volume. As we talk about the arterial natriuretic peptide in the before, in the short-term regulation, it acts on the volume, blood volume, not pressure, okay? And also we have cardiac factors, which is the heart rate and the contractility of the heart itself, okay? And then we will move to the peripheral resistance. So the blood pressure coming from the cardiac output or the peripheral resistance. The peripheral resistance have a neural factor and the humoral factor. The humoral factor, the hormonal that act on this vessel. So like the thing that constrict, we have the main thing, the angiotensin II. And the thing that dilate, the main thing, the prostaglandin, nitric oxide, the kinins also. For the neural factor, we have alpha adrenergic, which is responsible for the constriction of the blood pressure, and the dilator is beta adrenergic. In the pharmacological treatment of blood pressure, we will see the alpha adrenergic role and the beta adrenergic role in the drug, okay? And beside this, we have also local factors, which is the pH, as what we talk in the chemoreceptor, the hypoxia, decrease in the oxygen, or increase in the CO2, okay? Now we will move to the hypertension itself. So it's very, very, very important to know the classification of the hypertension, when it's a grade 1, grade 2, grade 3, very important. I remember that we have questions relating to this. So memorize the tables. And قبل ما تحفظوا تأكدوا عن التيبل اللي المفروض تحفظوه من الدكاترة اللي عندكم. Okay? Very important to know this. And also we have the hypertensive crisis, when the systolic blood pressure is more than 180 and the systolic blood pressure is more than 120. Very important. And the urgency and the emergency. Urgency when there's no organ damage, and the emergency when there is an organ damage. With this increase in the in this blood pressure, okay? Also very important to know this. Okay. Now we will move to the epidemiology and risk factor. Until now, if there's anything that you want to ask about? Okay, so let's complete. We have two main factors, or two main reasons for the hypertension, which is essential and the secondary hypertension, or the primary, the essential, which is called also the primary or the essential, okay? And we have the secondary. Essential when it's there is no reason behind it, or there is no any other factor that make this hypertension, okay? But the secondary hypertension, there is another source or another thing that make the hypertension appear. For example, if we have aldosteronism, which is when we have an increase in the amount of testosterone, and if there's any bicuspid aortic valve or the plaque races where they have for this hypertension, okay? And we have also a correction of the aortic valve, aortic artery, like what you see here in the picture, when we have a constriction in the aortic artery here, so this will increase the afterload, so this will lead to increase in the blood pressure, okay? And some drugs like the NSAIDs, cocaine, all this, and also the diabetes could be a risk factor. Also, the other cause, the endocrine cause, like pheochromocytoma. Here, in pheochromocytoma, here when there is an increased amount in the adrenaline, noradrenaline, we have tumor in the medulla of the kidney, of the adrenal gland, which make the adrenaline, noradrenaline in large amounts. So because of this, we have this hypertension. So it's a secondary type, which is a pheochromocytoma. And as what we see, the black people have more prevalence for hypertension. Okay? So yes, here it's very important. The black patient more salt sensitive. They are more salt sensitive and low renin hypertension. So they will respond better for the diuretic and the calcium channel blockers. and they will not respond good for the SASE inhibitor alone. Okay, very important. So let's move to the pathophysiology of the blood pressure. We have, you can say main three reasons for this blood pressure. First, the salt sensitivity. Who will be affected more? As what we say, the black people more, 73. They have high prevalence in black population. Salt cause vascular dysfunction. So the salt can cause vascular dysfunction and increase the peripheral resistance. So this all will lead to the hypertension. It's very important. So the salt have main three pathways to activate this vasoconstriction or to make the blood pressure. First, it can stimulate the G protein in some subsets and make the vessel tight, muscle contraction, stimulate the muscle contraction, okay? Or work in this kinase pathway, RHO kinase pathway, which here will keep the vasoconstrict, block the relaxation. So it should be relaxed, but the salt come in this kinase pathway and block the relaxation. So also we'll have vasoconstriction. And also if there is any interruption in this bond, sodium-potassium bond, so this also will increase the muscle tone. So the salt have likely causes vascular dysfunction by these main three pathways. Okay, here in this picture you can see mainly it's by the genetic influence. It may affect in renal sodium homeostasis. So there is inadequate sodium excretion, so the sodium will be in the blood, and this salt and water retention will increase and have a high volume in the extracellular fluid. So this will increase the cardiac output, and يكون برا الأوتو ريجوليشن فيحصل البلد بريشر هذا تمام الهايبرتنشن. أو إنه يكون عندنا functional vasoconstriction genetic influence functional vasoconstriction يكون أصلاً في vasoconstriction في blood vessels, so this will increase the vascular reactivity. Here I forget to say that the natriuretic hormone, when there is high plasma extracellular fluid volume natriuretic hormone, okay, this will increase the natriuretic hormone. And also the last thing here, the defect in vascular smooth muscle, the genetic influence, if there is defect in the vascular smooth muscle growth and structure, this will also increase the vascular wall thickness. Both of them, they link to each other. Both of them will lead to total peripheral resistance to increase this. So we have hypertension. So as what you say, we have either cardiac output problem or the total peripheral resistance problem. Okay, and here in this picture, you can see the blood pressure, blood vessel. What will happen? Decrease in the nitric oxide. We know the nitric oxide work as a vasodilation. So when we have increase, this also will lead to hypertension. So the picture is talking about the factors that make the hypertension. For example, decrease in nitric oxide, increase in the endothelin production. Endothelin work opposite of nitric oxide. Okay, but also here the important thing. Yes, I think we have covered this. Okay, this is the first one in the pathophysiology of the blood pressure. The second thing we can say, the obesity, it's linked to the hypertensive by three main pathways, you can say. Adipocyte release angiotensinogen, part of blood pressure raising RAS system. As what we say, the angiotensinogen when it go out, it will increase the blood pressure. So the adipocytes have this angiotensinogen. And also increase blood volume from higher body mass. We have hyper body mass in the obesity, so this will increase the volume, of course. And also with the thicker blood, increase the viscosity. Due to adipocyte release of clotting factors. Also this adipocyte could release clotting factor like BRAF, fibrinogen, BAI1. So this will increase the hypertension in the obese people. Other contributing mechanism like lifestyle factor, genetic factor, vasoconstriction, anything can cause the vasal narrowing like For example, the stress could cause this vasoconstriction, so it's considered a risk factor. Okay, neurobiological disorder, problem in the central nerve system, can also cause this hypertension or hypertension. Okay, clear? Okay. Now we'll move to the secondary hypertension before we have talking about the primary, where there is no سبب واضح تحت عشان صار عندنا hypertension. بس هنا secondary hypertension we have another cause that has caused this hypertension. For example, when we have the hypertension in the pregnancy, here when there is the placenta perfusion, it's not good, so this will cause hypertension for the mom, and we'll have proteinuria, preeclampsia, all of this in the hypertensive pregnancy. I think you will talk about it more in the next block. Now you will not talk about it. The other cause, it could be aldosteronism, because as what we said, aldosterone could increase the sodium in the blood, increase the water. The water always go with the sodium, okay? And also if we have any problem in the kidney, because how kidney can control the blood pressure? When it's feel like there is decreased blood pressure arriving to it, it will start secrete this renin. So if we have any stenosis in the renal arteries, this will lead to hypertension, because it will think like there is no any blood, so I will increase the blood pressure because there is no blood arriving to it. اوكي هي بتقول انه ما في blood واصل عندي، معناها انه في blood pressure، في blood drop in the blood pressure, so it will increase the blood pressure. but انه في الحقيقة ما انه ما في blood، بس انه في stenosis في الارتري، في الكدني artery. اوكي وحيصير في الراس activation، راس system activation. وكمان some other drug, for example contraceptive drug could make blood pressure sympathomimic, because there will be vasoconstriction, increased heart rate, increased contractility. Also the SSRIs, which is work in the psychiatry, we usually crisis. Okay, now here we have the equation for the blood pressure, as what we say, cardiac output and the total peripheral resistance. In the young patient, usually the cardiac output will be increased, and here we will have the blood pressure. So, for example, if there is a young male or female or patient have blood pressure, usually this because of the increase in the cardiac output. But if it's older, this will be mainly increase in the total peripheral resistance. Okay, because when the patient come I will put the slide. Yes, I think we have. No. Okay. طيب. ثواني 1 minute please. طيب إيه زي ما شايفين هنا في الصورة we have the cardiac output and the total peripheral resistance. When increase the age, the total peripheral resistance will increase, but the cardiac output will start decrease. So as what we see here, according the diastolic hypertension is more common in young people, but the people who are over 50 have isolated systolic hypertension, because there is The diastolic pressure rise until about the age 50, but the systolic pressure will increase throughout the life. Okay, so if there is young people or the young patient, usually they will have the cardiac output will increase. Okay, in younger patients with hypertension, elevated blood pressure tend to be driven by high cardiac output, as what we say, in the setting of relatively normal peripheral vascular resistance. Okay, term as hyperkinetic phase. Okay, يعني hyperkinetic اللي هم اليونجر patient اللي عندهم high cardiac output. However, the effect of cardiac output decline, perhaps because of the development of left ventricular hypertrophy. The cardiac output حتقل كل ما إنه الage صار increase. Okay. So the vascular resistance increase with age, but the vascular resistance increase with age. So we'll have a resistance high with the age, with increasing the age, due to medial hypertrophy as the vessel adapt to the prolonged pressure stress. Okay. يعني كconclusion لكل هذا إنه ال younger hypertensive patient إيش بيكون عندهم augmented cardiac output as the principal abnormality الشيء الأساسي. بس ال older patient tend to have elevated peripheral resistance. Okay, as major hemodynamic findings. تمام. Okay. تقريبا الكلام اللي هنا نفس اللي تحت. نروح للسلايد اللي بعدها. بعدين نروح هنا ال end or organ damage. What will happen for the organ when we have high blood pressure? I think you have lecture about this for Dr. Wael, so you can study from it, but I will make a quick summary for that. So we have the vascular pathway. First, we'll start by the vessel, the vascular pathway, either for large vessel or the small vessel. For the large vessel, this will accelerate the atherogenesis. I think you will talk about it more in the first case. And the degenerative change will have aortic dissection, cerebrovascular hemorrhage. Also, we have fibroelastic hyperplasia in the large and medial vessel. What will happen there? They will be thickening in the intima and the media. Okay, because you need a high pressure, high blood pressure, this will lead to thickening of this intima and media. يعني عشان تقدر resist the high blood pressure. But for small vessel, what will happen? Either we have hyaline arteriosclerosis or hyperplastic arteriosclerosis or necrotizing arteriolysis. So the hyaline arteriosclerosis in the benign hypertension, which is a pink hyaline thinking. This will lead to lumen narrowing and ischemia for the organ that it supplies. Okay, so it's happened chronic hemodynamic stress, protein leakage from the vessel, and there will be a hyalinization. Okay, but the hyperplastic arteriosclerosis, which has happened in the malignant hypertension, it's look like onion skin thickening. Okay, this will lead to severe lumen narrowing. And then necrotizing arteriolysis, which is fibrinoid necrosis. We'll see this in the vessel death, and it's yes. Here, what happened in the cardiac, في الهارت يعني very 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 important this picture. So first, let's start by this picture here. طيب إيش عندنا؟ أول شيء عندنا اللابلس لو T, which is considered as the stress, B the pressure, R the radius, the H is the thickness of the wall. Okay, so if we have pressure overload, okay, what will happen in the heart? The stress will increase because we have pressure overload. This pressure overload will lead to decrease the radius and increase the thickness. Why? To decrease this pressure. يعني في high pressure في الهارت إيش حيصير؟ الراديوس حيقل. ليش حيقل الراديوس؟ لأنه صار عندنا thickness في الوال. طيب في الثيكنس في الوال هذه صار إنه قادر تتأقلم مع البريشر الهاي هذا. تمام، فهذا بنقول لها الكونستريكت هايبرتروفاي. تمام. أما هذا إذا كان في pressure overload. But if we have volume overload, what will happen here? Also the T is high, meaning there is high stress in the heart. What will happen? This here, because we have a volume, the radius will increase. When the radius is increased, to overcome this volume overload, but also we will have thickening in the wall also to عشان تستحمل هذا volume overload. But here when there is the radius increase, it's called the eccentric hypertrophy. Okay, so we have concentric hypertrophy and eccentric hypertrophy. The difference that here the volume is high, so there is increase in the radius more, but here the radius will be decreased. Okay, here in this picture, which is also important, when we have left ventricle pressure overload or volume overload, first we'll have the constrict remodeling, not like hypertrophy, it is still just remodeling. Okay, so we don't know, maybe heart failure or maybe not, because it's just remodeling not hypertrophy. Okay, بس لما نيجي للconstrict hypertrophy إيش بيحصل؟ ممكن preserve ejection fraction حيكون تقريبا نفسه، لأنه صار في hypertrophy في الوول، فإنه ejection fraction يمكن يكون نفسه، بس حيكون في heart failure. تمام، هذا preserve ejection fraction heart failure. تمام، لأنه صار خلاص hypertrophy، بس الأول كانت remodeling just remodeling. have constrict hypertrophy. The last stage, or we can say if there is eccentric hypertrophy, the radius will increase and the ejection fraction will decrease. Here the ejection fraction will decrease because خلاص the radius become high and ability of the heart to pump blood بتكون less. Okay, so we'll have reduced ejection heart failure. Okay, في الconstrict hypertrophy قلنا يمكن preserve ejection fraction مع heart failure، بس إنه إذا صار في myocardial infarction it could lead to the reduced ejection fraction heart failure. Okay, and here we have the risk factor that could lead to this: ethnicity, gender, obesity, diabetes, salt intake, all of this. Okay, خلينا نقرأ الكلام اللي هنا. الconstrict remodeling اللي هو mild change will thicken slightly. Chamber doesn't enlarge. لسه ما في chamber enlarge. May or may not lead to heart failure. هذا عشان في استفهام. Still early stage اللي هو mild change اللي هو constrict remodeling فقط. But في constrict hypertrophy يكون عندنا severe thickening of the wall. The wall gets very thick. Chamber small. Chamber خلاص start to be smaller. The ejection fraction, which is how the heart will pump, often preserve. بيكون لسه still good. Try to compensate the heart, but the heart will become very stiff. We may have heart failure, but it's preserve ejection fraction. Okay, heart failure, preserve ejection fraction. Can turn into worse heart failure if there is a heart attack. Okay, MI. Eccentric hypertrophy, where the chamber enlarged. Chamber gets big, wall stretch thin. The ejection fraction will decrease, so we'll have heart failure with ejection fraction. Okay, I hope it's clear now. Now we'll talk about very quickly this here, because I think you have the lecture. Benign and malignant hypertension, the benign hyaline arteriosclerosis, as what we talk, malignant hyperplastic arteriosclerosis, and fibroid necrosis. Fibroid necrosis, the last stage. Cotton wall spot in the eye, the nerve fiber layer infarct, there'll be infarction there, so retinopathy. Burkhardt aneurysm, which is in the brain, microaneurysm in the brain. If it's rupture, we'll have small hemorrhage. Then slit hemorrhage, we have the acute hypertensive encephalopathy when there is blood pressure more than 130, diastolic blood pressure. The left ventricle hypertrophy is what we talk about it now. Okay, what will happen to the kidney? We have either benign or malignant. The benign, usually it's a chronic, moderate, slow, insidious. The gross appearance will be symmetrical atrophic granular surface because the both kidney have this deficiency in the blood, so it will be symmetrical. We'll have a hyaline arteriosclerosis in the benign, but in the malignant we will have fibrinoid necrosis with hyperplastic arteriosclerosis. Okay, the glomeruli, how it will be sclerosis in the late stage, but here it will be necrosis with microthrombi. We have microthrombi because there is a lot of hemorrhage in the malignant. Okay, The inflammation, it will be absent in the chronic, but may be present in the malignant. Okay. Slow CKD progression, chronic kidney. Okay. The acute kidney injury, possible rapid failure because it's acute and malignant. Yes, this what will happen, like a summary for what I have said. We can have a mnemonic for complication, heart failure, eye retinopathy, aortic dissection, renal failure, and thromboembolic stroke in the cerebra. The last thing we'll talk about the treatment. We have the non-pharmacological, the pharmacological treatment. The non-pharmacological first will start by DASH diet. Very important to know the DASH diet. I think, yes, you have to look for it and memorize it very well. And weight loss, exercise, smoking cessation. We have also mnemonic here, you can see it. For the pharmacological treatment, also you have a lecture, you have to memorize it very well and ask the doctor about the thing that you have to memorize, they say to you. Okay, we have main 4 classes we can say. First, the diuretic, which is responsible for the volume. So if we want to decrease diuretics, no diuretic, all the diuretics. And if there is any problem for the heart or the cardiac output, we'll use the symptomatic, like beta blockers, alpha and beta blockers, central alpha 2 agonist. The central alpha 2 agonist should be agonist, not antagonist or blockers. Okay. Also, we have the vasodilators, which will decrease the vascular resistance, will dilate the vessel. Okay. And then we have the RAS antagonism for peripheral vascular resistance and sodium retention. Okay, and here we have like summary before I end. We have the thiazide diuretic, like this drug, and usually it's best for plaque, elderly, and salt-sensitive patients, and it's avoided in the gout and severe kidney disease. Okay. And then we have the ACE inhibitors, like Pril, any drug ending by Pril. And it's best to use for diabetes mellitus, heart failure, but I will avoid it in the pregnancy, okay? And bilateral renal artery stenosis. The ARBs يعني بيشبه ال ACE شوية, بس الدرج نهايتها سرطان. If there is any patient that have to tolerate the ACE, we will use the ARBs. And will be avoided as in ACE. Then we have the calcium channel blocker, amlodipine, and it's used for elderly patients, as related cytosolic hypertension also, but I can't use it in the heart failure. Okay. Here we have a mnemonic for the first line: ABCD, ACE, beta blocker, CCP, calcium, diuretics. And for the plaque patient, we will start by the calcium channel blocker or the thiazide. We'll not use the ACE. For the diabetes, we'll use the ACE and the ARB. Okay. Yes, I think that's it. I hope you get benefit from this presentation. If you have any question, you feel free to ask.
يعطيك العافية دكتورة آيات. إذا في أي سؤال اكتبه بالشات.
يعافيك.
يعطيكم العافية. Is my voice clearable?
إي واضح.
Okay. Are you able to see the screen as well?
لا مو واضح السكرين.
Okay.
في أحد سأل في الشات.